Hola, I'm Nelson Decamp, chiropractic physician in the U.S. I'm a diplomate in neurology and a fellow in craniopathy. I've been in practice for 55 years. My first degree was in engineering. The main thing I was taught was you can't fix something if you don't know how it works. So I became a human engineer, and with my diplomate in neurology, have done extensive research over the years and produced about 20 papers, my latest paper being established specific neurological testing for the upper and lower SI joints, which control the cranium, the main weight-bearing joints of the body. For 40 years, I have taught multiple series of seminars in multiple colleges, one for 20 years, and all over the world, including 3 years in Brazil, and I still do research. The following presentation is a brief overview of sacro-occipital technique, SOT, and chiropractic craniopathy, which is the only chiropractic diagnostic and treatment system with the focus on integration of the CNS, the brain spinal cord circulatory system, and CSF, the cerebral spinal fluid. For further information, go to S.O.R.S.I, S-O.R.S.I, Sacro-Occipital Research Society International.com. You may also check Amazon for multiple osteopathic books under the subject of craniopathy. Now, let me explain. I've got an awful lot that I'm trying to tell you, and I also want to try to keep it in some order. This took me quite a while to be able to nail this, bring this down. This is about 3 or 4 weekends worth of work in 1 hour. So you may want to watch this a second time, but I'm going to be reading most of it and then filling in and expanding what I come up with. Okay, all colleges and the medical sciences teach the basics of healthcare, anatomy, physiology, etc. They also teach therapeutics and procedures for the relief of symptoms and complaints of the patient. The MD is educated in the use of pharmaceuticals, surgery, and possible physical therapy. The DO offers the same, but has also some generalized joint manipulations. The D.C. offers specific joint manipulations and some physical therapy. To varying degrees, chiropractic colleges also provide introductory classes in various areas of further advanced chiropractic systems of analysis, diagnosis, and treatment available for future study, certifications, and expanded healthcare proficiency to their patients. Unfortunately, a great many graduates enter practice offering only the very basic generalized care for aches and pains in general maladies and not seeking the source of the symptoms. Our biophysiological functions in life are quite durable with extensive compensational abilities to withstand multiple stresses, acute and long-term, traumatic, and biochemical. When or as they develop to the end of their compensational physiological adaptation, symptoms begin to develop. I always relate to my patients about the toothache and the cavity. How big is the cavity when the toothache develops? Root canal and extraction time. Treating symptoms and not causes allows the causes to continue to increase in their degeneration and pathology, which eventually may result in permanent damage, functional incapacity, cancer, and even death. I always explain to the patients that it took us a long time to get to the age we've reached. And in the process of doing this, we have experienced a lot of falls, trauma, things that have occurred and happened over a lifetime. And gradually the body is compensated for one thing and it compensates for another. And I tell them by the time you get to 80% of the contracture, something maxes out. And that's where we start getting aches and pains. Oh, it came once a month, and then it was twice a month, and then it was only in the afternoons, and then I woke up with it in the mornings, and it's gradually built and built. And of course, patients don't do anything until they can't cover the symptom up, which is the medical field. So many of you will find that a lot of the patients you have are patients that have been under medical care for a period of time, but aren't getting any better. So as a last resort, they're going to go try to find out how to fix the damn thing. To treat the cause, we need to become knowledgeable physicians, not symptom technicians. In chiropractic, there are many systems of analysis and treatment available to us. Some are very basic, and others are very involved and require ongoing learning. We have to stop and think, what level of care is expected? What do you plan to provide? What if they are your parents, your spouse, your children? This presentation is designed as a brief recap of the central nervous system, cranial sacral respiratory system, and ultimate care you can provide to your loved ones and patients. This is the only system of analysis and treatment in chiropractic that can be integrated with chiropractic spinal care and greatly expand your therapeutic system to the brain, structure, and function. A human is made up of billions of cells, which continuously provide various types and levels of metabolic activity as needed to maintain harmonious integrated functions of all body systems to provide for the demands of optimal life physiology. There are three basic primary integrated systems of function. The first and main one and the controlling factor is the brain spinal cord, the central nervous system, or CNS. This biological computer system made up of billions of microchips, nerve cells, which on bioelectric and chemical stimuli integrate and develop patterns of output as well as storage to establish who we are. The system works 24/7 and is the most metabolically consumptive system in the body. The CNS consumes oxygen, blood sugar, and nutrients involved in their consumption at a ratio of 7:3 to the other cells of the body on an average body. That does not include the doctors and people that think for a living. This is provided only by the circulatory system of the cerebrospinal fluid system, CSF. The next thing that's of importance is the organ system. The organ system, which breaks down the complex ingested substances to create and provide the chemical elements necessary for cellular metabolism or metabolic activity of somatic physiology by blood flow and the primary CNS. The structural or biomechanical hunter-gatherer system to provide the organ system with the needed resources for the metabolic processing to support the activity of all three systems. So the main thing is the brain, and it has two guys working for it. One is the organ system and the other is the structure system. The CNS is so variably active and metabolically consumptive that it requires a separate circulatory system of its own. This is nutritionally supported by blood flow from the cardiovascular system from the organ system, which is filtered through the blood-brain barrier. The CNS is also important in that it is enclosed in bone and can only be contacted by a knife or puncturing the bone. That's how important the nervous system is. And this is important. The body will do everything it can to maintain who we are, period. It'll sacrifice anything. When your brain is in trouble, you're in trouble. And that's when the smoke alarm starts going off. In uterine, various variations of embryonic developmental metabolic demands are minimal and met by the nutrition and oxygen reserves of the mother. On birthing, all of a sudden, our nutritional metabolic demand for continued development increases tremendously. and is supplied orally through the infant's digestive system, normally with a drop of oxygen to support the ongoing major developmental demand. The diaphragmatic neural system responds, and a diaphragmatic respiratory cycling is initiated to supply oxygen and eliminate CO2 and meet the extensive variable demands. In future life, if the diaphragmatic respiratory cycling does not begin spontaneously, the infant is held by the ankles in an inverted position to increase the CSF pressure in the cranium to release the cranial sutures and allow for inter and intracranial bone flexion extension. A sharp thrust is then given to the apex of the sacrum to create a flexion extension of the lumbosacral articular junction, which is transmitted neurobiommechanically through the spine to the cervical cranial articulations to stimulate the synchronous variable diaphragmatic respiratory neuromuscular reflex function. We have now established that there are two CNS, cerebral spinal fluid circulatory systems involving the cranium. The CRI, clockwise rotation, go back here. I think I mentioned we have metabolic supply of the neural development for the in the ovum that's starting is 12 to 14 pulsations a minute and is generated by the glial cells in the brain. And you've all seen pictures of the embryo where you see the skull about this big and the body about this big. And the first thing that develops is the computer system. And after about 2 weeks, 3 weeks, then you start developing organs. The computer system is built up. Now the organs start developing. And so in about the second or third week in uterine, now you start a heartbeat. Now the heart starts pumping to start the somatic development of the neural and non-neural cells. And now the heartbeat becomes audible. So now we have the two systems. The counterclockwise rotation of the CRI, craniorhythmic impulse, by the glial cells is 12 to 14 cycles per minute, and then the diaphragmatic cranial pelvic flexion extension sets in, and that's according to the respiration. The subcranial musculature, innervated by the C1, C2 spinal nerves and the trigeminal nerve, which is in the stem, brain stem, exerts an inferior force on the cranial bones around the focus of the spine. This creates a flexing of the cranial bones with a center of action at the sphenobasilar synchondrosis. In most cases, subcranial muscular contractions with postural compensational involvement from the way you're standing during inhalation creates an imbalance, flexion and extension and intorsion with the occiput on the sphenoid. This translated anterior into the front bones and involvement with the sensory motor neuron response of counterbalancing muscles of mastication. Excuse me. These CSF pumping system are well plasticized in the brain for the primary function of life. Facilitation and plasticity of the neuromusculoskeletal postural adaptation patterns may create hyper or hypo dysfunction, motion dysfunction of certain cranial areas. All other functional area activity is secondary. So if you decrease the food supply, the oxygen to certain areas of the brain by distortion of the cranium, those cells are not getting as much to eat, and therefore they're not going to function at the same degree. So here we have, this is diaphragmatic. The brain starts to move. There's on the bottom, you can see the schiena basilar, and we see flexion and we see extension. And that's the beginning of it. Here's another picture here, flexion, extension. Now every time you breathe, that's what happens. When you do, if you notice, this is the tentorium. When the cranium, when you breathe in and you have flexion extension, the whole skull, think of the skull opening up like a blooming flower. And when the temporals come out and the occiput drops back, that flattens the tentorium, which pumps the cerebrospinal fluid down to the sacrum. So we have movement of the cerebrospinal fluid at 12 to 14 times a minute through the CRI, cranial rhythmic impulse. Now we add the respiration to it. And so while it's circling all the way down to the sacrum, now we're pumping it up and down as well. Now remember, it has to go all the way down the spine, out the nerve roots, all the way to the receptors at the end. Those nerves that we have going to all our organs and all our muscles have to eat also. And that's the direction it comes in. So you have to always look at this. Always remember, that's got to balance. If you've got a patient with a headache, that cranium is locked and it's no longer moving and it's having to go into spasm to try to get it. It's going to always maintain cerebrospinal motion flow. It'll do anything in the world, but it's not going to allow you to die. So that's the primary thing it's going to do. Okay, now what I'd like for you to do is I want you to just take your arm, just put your hand on it. And I just feel it lightly. And then I want you to breathe deep through your nose and out. And do that a couple times and you'll feel the energy flow right down the muscles. All right, now hold your breath and feel that same flow of energy go down the arm. That's the CRI. That's from the glial cells. So now you have felt both of the motions of cerebrospinal fluid through the body. Now, if you keep your hand there, now when you hold it, you can feel the heart pulse. Cardiovascular. So we have 3 types of blood flow, 2 in the brain, the central nervous system, and 1 for the somatic system. The main thing the somatic system does is feed everything. Okay, so as we previously mentioned, there's 3 main integrated circulatory functions. The primary one which controls the integration of all of them. The brain deals with through the hypothalamus, the organs. That's what controls the organs. That's one of the other system, the structural biomechanical system, is controlled by the neuromuscular system in the brain. So it's controlling both the other things that are supporting the CNS. So the CNS is doing everything it can to make sure it functions at maximum capability. Unfortunately, the primary system, the CNS, has only experienced expanded research efforts over the past 150 years. This included the most important circulatory system, the cervical cranial system of the CSF, and the mild to severe effects of human brain function due to metabolic aberrations of CSF flow in various areas of the brain. So they started realizing that when you don't have a good flow of CSF through the brain, you start getting symptoms and you start getting pathology throughout the body. metabolic aberrations as well. The interest in craniopathy started with the thinking and the hands-on investigation of a teacher physician, Andrew Taylor Still, in 1829 to 1917, who created osteopathy in 1874. His emphasis in treating patients was to reduce all perceived mechanical obstructions to free-flowing rivers of life: blood, lymph, and cerebrospinal fluids. He formulated his innovative thinking regarding the cranium and the cranial nerves and proclaimed in 1899 the cerebrospinal fluid, CSF, is the highest known elements that control the human body. William Garner Sutherland, 1873-1954, who as a student of Dr. Still, developed craniopathy in the osteopathic field and expanded its development not only in the US, but throughout Europe. He developed craniopathy into an applicable technique and published in 1939 a small text titled The Cranial Bowl. An excellent expanded text, Osteopathy in the Cranial Field, was written by H.I. McGowan, an osteopath, in 1966. During the period of time that these texts were the basis of osteopathic cranial technique, the emphasis was on the cranium itself and its correction. Not much research, writing, or teaching related to the lumbopelvic complex or postural compensations. Therefore, due to many adverse compensational reactions to cranial corrections and the gradual diminishing osteopathic involvement in spinal manipulation, development and the practice of craniopathy waned in the osteopathic field. In 1983, John Upledger, D.O., produced a text called Craniosacral Therapy. In this text and additional following text, the previous cranial bone manipulative procedures were limited. Therapeutic light touch and craniorhythmic impulse energy balance was taught so as to not upset compensation or patterns of dysfunction which had created adverse reactions in patients. This is presently being taught throughout the country, mostly to non-primary healthcare practitioners, massage therapists. In 1927, M.B. DeJarnette, osteopath and chiropractor, with osteopathic training before becoming a chiropractor, established sacro-occipital technique and published his first text in 1930. He had experienced significant relief with osteopathic manipulation for severe injuries sustained in an industrial accident, and this inspired him to enter osteopathic college. During this time, he became acquainted with Dr. Sutherland and had experienced successful craniopathic care, although not without the adverse reactions. In personal conversations with him, he stated, "I have experienced reactions to cranial corrections personally and was bound determined to find a system of analysis and treatment to eliminate the reactions to the cranial adjustments. Correcting the cranial function and releasing the stress from the central nervous system is the ultimate goal in health." In 1965, DeJarnette felt he had sufficiently developed a system of objective analytic indicators and treatments known as sacro-occipital technique, or SOT, to clear the cranium sacrum of the compensational causes of cerebrospinal fluid, CSF, pumping function. He published Cranial Technique and began teaching chiropractic craniopathy in 1968. He also established the Sacro-Occipital Research Society International, S.O.R.S.I, to continue the research and teaching of SOT and craniopathy in the chiropractic field. A recent text on craniopathy is an excellent one, and explains a lot. Is the Chiropractic Manipulation Theory and Practice, written in 2005 by Leon Chaitow, osteopath. This includes the history, practice, and research within the osteopathic, chiropractic, dental, and massage therapy fields. Missing is the neurophysiology of the cranium and sacrum that is the basis of SOT correction developed by D.J. Sacro-occipital motion has been established by multiple authors, all agreeing that there is a biological or biomechanical range of motion adapting to SI joint loaded stresses and dysfunction. Many of these authors refer to the osteopathic concept of synchronized craniosacral respiratory motion with torsion as an association of the mechanisms of involved CSF pumping, with flexion extension of the cranial osseous and dural systems. There is reciprocal extension, flexion of the sacrum and the pelvic system. The sacrum consists of osseous segments, which, like vertebrae, have similar characteristics to the rigidity and flexibility. These factors establish the ability for a slight intra or intersacral motion in the craniosacral respiratory function. And so we look at the sacrum, and it's important to understand the weight bearing comes on the S1 area. This joins with L5, and this is where all the weight is to support the function. The dura attaches to the posterior part of the S2 tubercle, and the lower part from S2 up and down flexes. So you have two areas. You have one S1 area, and that's the weight-bearing area. That has a whole set of neurology that balances for postural, primarily. The second is, that is weight support. When you go down to the S2-3, that's not so much, it is weight support, but it's more so weight support with the ability to move. And this is important. Now, when you look at the ligaments, or look at the sacrum, these are actually sacral segments. As a matter of fact, you can put your fingers on the sacrum, S1, 2, 3, 4, whatever, hold them there and have the person breathe deep, and you will actually feel the sacrum flex individually. Each of the sacral segments move. They've got discs in them, but not like vertebral discs, but they got discs, so there's a flexibility. And then if you look, you'll see that there's ligaments that go to each, from the iliums, that go to each one of the sacral segments to support the individual sacral segments. You can actually go down and palpate these sacral segments and determine which part of the sacrum is out of place or is causing the problem. So the Lovett relationship. We all are familiar with the Lovett relationship. L5C1 balanced together, L4C2, at the same time sacrum and the cranium balanced together. So S1 balances with the base of the cranium. So S1 balances. Here's the dural attachment right here with the cranium. This is where the tentorum is. That's where the flexion takes place. And so this right here is just like the S2. That's the attachment of the dura at the bottom. So every time you breathe and this drops down, it puts a stretch into the tentorium to pump the cerebrospinal fluid. And it has to balance. You can turn this upside down like this, and that's the same thing as the sacrum. Here's the S1, here's the S2-3. And there's the C1. So you have to just, when you look at the patient, you can just turn the patient the other way. If you're holding the head and looking at the head, what you find with the head is happening at the sacrum, because they both got to work together. So if you have, if the atlas is balancing for L5, and the base of the occiput is balancing with C1, any distress or this irritation, inflammation, pain that comes from here relates to S1 sacrum problem. If the problem you're feeling is up with the occipital parietal, then that's going to be the S2, 3, 4 area. And so when you have that torsion, a lot can occur. Now, I don't know if you can, how well you can see this. Can you see how this back here, this should be the falx cerebri, that should be a straight line. Can you see how deviated that is? Right in the middle. Also look, the foramen magnum should be round. Can you see how it's torqued? See, that should be round. And you can see how much torsion there is there. The other thing you can look at, of course, you can't do it on a patient, but if you look at the joints, you will notice the joints are at a different level. This one comes down farther than this one. And when you look at them this way, can you see how one is lower, the other is higher? So here how low that is compared to that one. So that's where all the torsion is coming, right into the occipital bone. And it's got the whole back of the whole tentorium out of balance, which is going to affect the temporal and the occipital lobes of the brain. So we have a balance. We have a balanced system that's constantly going on with the body. Number one, we know that the brain and the cranium, cervical cranium, has got its own thing to be able to pump cerebrospinal fluid. At the same time, the body has to be able to play football, has to be able to go dance, has to be able to walk. It has to be able to do a lot of things. And so with that, we have two different systems doing the same thing, and we have postural and we have volitional muscle. The postural muscle is divided into the upper cervical and pelvic. See if I can get this so we can read it.
Right, hold it up. What are you doing? You gotta hold it flat.
Yep.
No, that's not gonna work.
No, it's not going to work. Okay. But anyway, if you can read backwards, you can see we're talking about the lumbosacral plexus down there. That, and then we've got the brachial plexus, the lumbosacral plexus, and the brachial plexus balance the spinal posture. That intersects at C2 and C1, and then you have the trigeminal spinal and spinal nucleus and the cervical cranial syndrome. So one system balances with the other. And essentially looks like this. And so everything below and everything above C1, C2. That's where the upper cervical people, all they're doing is banging into compensation, where the two systems are trying their very best to balance and maintain health. And they just keep breaking up and disrupting the balance. Now, it's important patterns of postural and physiological dysfunction due to the cranial, cervical, and pelvic spine, pelvis spine imbalanced compensational patterns are accumulated over years and require their finding their cause and applying correction over time using pattern indicators to monitor the ongoing improvements to the patient and to you, so you can see whether or not you're doing something for the patient. SOT and cranial courses teach these above patterns for diagnosis and treatment. Teach the diagnostic indicators for these patterns of dysfunction and monitor the corrective procedures. A lot of times you'll pick up things before you get to the 80%, because as you start palpating the patient and you find this side is different than this side, you start learning which ones, where to associate it, what to associate it with. We mentioned already the fact that you can use the occipital mastoid and the occipital parietal sutures to determine stress into the S1 or the S2-3 sacral area. At the same time, any problem up there is going to create a constant problem in the SI joint. If you correct the SI joint, it relieves the pressure here. If you don't balance the changes that have been made, as you saw in the cranium, then the cranium reestablishes the SI joint problem. And these are the patients that you've been treating for so long, and they just refuse to get better beyond a certain point. It just keeps coming back because you're not balancing one end with the other end. So there are various things that you learn in SOT. And there's one guy, there's two medical doctors in Switzerland. And these two medical doctors in Switzerland put out a book called Manual Medicine. And in there, they went through and they found all kinds of things. They went through the spine and they would put an irritant at a spinal level and irritate that joint. And then they would go through the whole body to find out where the muscles involved were, and how did it react. And so they've got a page in the book for every single level of the spine. Now this one is, that's T6. This is T5. And it goes beyond that. I mean, every single level. But you can't look at all these different muscles in there. It would just take you forever and a day. So if you notice, you've got muscles down here. You've got muscles up here that you can use. You've got the love-it relationship up here. And so you've got certain patterns that work. Here's one of the ones that we use that we teach in S.O.R.S.I. And this is what we call the gluteal indicators. So depending on what sacral segments are involved, you can just palpate the gluteal fibers. You know, you have to stop and realize if you look at the body is made of triangles. And so when you have a triangle, it comes down to a certain area. When you look at the gluteal muscles, L5, L4, 3, 2, 1, 11, 12. So as it goes up into the lumbars with the cervicals. Well, look at the muscles that attach on the occiput. If you come over here, you can go from one all the way, and you will find that there are 7 tendons that come off the base of the occiput going down to the cervical vertebra. On the other hand, you can come across the trapezius, and you will find that there's 7 points that function with the 7 vertebrae. And you will find that in SOT, they will teach you with the gluteal indicators that there's 7. And I just went through them. There's 5 lumbar, then you go to T11, T12. Those are lumbar vertebrae with 2 ribs attached to them. You got 7 movable vertebrae on the bottom, 7 movable vertebrae on the top. So you got 7s, this big magic number there. One of the things he has in his book was this one here. And you can look at all the different keys, all the different things he's got listed there, all the different muscles. And this is part of the pattern. This is just the pelvis. He's got other pictures in there showing other things. In SOT, what we use is this is what D.J. put together. He did this took him about 30 years. And he recorded every single patient that came in. He would check all the trapezius indicators across here. He would check the occipital fibers up here. He would check the gluteal fibers. And he was able to put together all of these numbers. And he kept doing this patient after patient after patient. And after about 30, 40 years, he accumulated the patterns. So if you have a vertebra that's in trouble, if you look, you'll see which other vertebrae are balancing for it to get the pressure off. The pain may be a symptom, may be up here, but the problem may be down here because this problem is shifted all the way up to here. But this is what we teach in SOT and craniopathy. Analysis is based on the understanding that the body attempts to maintain total physiological and postural balance patterns from head to toe. Once the patterns are understood, we can use palpable indicators of their dysfunctional systems to find the cause for correction and to rebalance the system. If you find a symptom somewhere and if somebody says this hurts, you can look up all the things that are associated with that because that may be the breakdown in compensation. That may not be the problem. You may have to go somewhere else. That hurts because it's taking the pressure off something else. And you can be working on these patients forever. And if you don't find out the reason why that hurts, you're never going to get them better. And it might be you. And it might be your wife or your husband or your kids or your parents. And you don't want them to go through life that way. Always remember, by the time you got the symptom, you got 80% of the problem. Whether it's an organ problem, whether it's a brain problem, whether it's a neuromuscular problem, whether it's a pain problem. It doesn't 80% of anything. Once you get to where something is up to that point to where it has become a symptom, you're in trouble. And you don't want to wait until you get so much degeneration that it's not fixable anymore. Over the many years of my SOT cranial corrective procedures, I have had tremendous success in eliminating or significantly reducing mental retardation, learning disabilities, speech defects, debilitating migraines, eyes, ears, throat problems, etc., in children as well as adults. Also, chronic and frequent episodes of blood pressure, heart, lung, GI problems from the spinobasilar area, hypothalamus. Of major importance has been the mental cognition through life and the Alzheimer's in the retired. You'd be surprised at how many students you can get, and you adjust them and you release the cranium, how they keep coming back, especially just before exams. They can't believe, my God, I can think again. And they've been beating their brains out, trying to study and trying to learn, and they just get foggy because they don't have the circulation. They don't have the oxygen and the chemistry to be able to feed the cells. It's not getting to them. So you've got to open up the circulation for people to think. People say, well, it takes too much time. It's too much trouble. Once you start finding these things, when a person walks in, you can ask them a couple of questions and you automatically know where to go. And all you got to do is check a few of the indicators to make sure you're right. Because you learn to think total person, not the individual thing. You've got to look at anything comes up, well, how does this fit into the total body? And that's what's important. Due to the extensive volume of patients coming into my practice, especially referrals, and those who have been unable to get help anywhere else. Now, please understand, I'm in Florida and I got patients that come from Cairo, Egypt. I've got a couple from France. I got one from Germany. I've got a couple from Colombia, South America, all over the United States, because I'm the only of who I am and what I do. I have a lot of people that I can refer back to, and I have a lot of guys, most of the people that I know that do cranial work are so damn busy they haven't got time to do anything else. I was working 10 to 12 hours a day and had to expand my office treatment area by 4 times and bring in more DCs to help handle the cases. In my 70s, I became physically disabled for 6 months. Unfortunately, after surgery, was able to return to a very part-time practice in France. But you have to remember, to be successful in life and practice, you have to learn and you have to become proficient in what the competition does not do. Believe me, you don't have to advertise for patients once you start getting them well. And they can, and especially ones that have been somewhere else first. They come and they know that it's the only place you can go. I got people that didn't like me as a doctor, but they're scared to death to go anywhere else because they don't do anything. I'm the only one that gets them well. I'm the only one that looks for these things that are there. So you have to get involved. You have to learn. You can't just go to high school and expect to get a job that people are expecting you to have a master's degree in or get a PhD in. You can't do it with a high school education. You've got to continue to increase, and this goes on for your lifetime. I'm still writing papers at 82, and I still learn, and you can too. My very best of luck to all of you. Please get involved in what you do for a living. It makes the whole thing worthwhile. Otherwise, you're just spinning your wheels. Okay, I thank you very much.